Sir Francis Bacon said that all rising to a great place is by a winding stair. And I'm not sure that I've arrived at a great place, but it certainly has been a winding stair. It really began when, in 1974, Dr. David Kupfer and Dr. Thomas Detry came to the University of Pittsburgh to found a new scientific department of psychiatry. At that point, I was a young mother at home with 2 children and had a little side gig on one of the local television stations doing a talk show on women's issues. My undergraduate degree was in theater, followed by a master's degree in English literature, all of which prepared me extremely well for a career in psychology. But more to the point, along with Dr. Detry and Dr. Kupfer came Carol Anderson to head the new social work program. The Kupfer-Detry team brought 27 people with them from Yale University to found this new department of psychiatry. So I had heard a lot about Carol Anderson's work. I thought it was very relevant to women's issues. I had her appear on our television program, and Carol promptly went back to Drs. Detry and Kupfer and said, "I've found our new research assistant." Well, it turns out that Kupfer and Detry had a research assistant whom they very much wanted to bring to Pittsburgh. She had brown hair and brown eyes and had a talk show on women's issues on the radio in New Haven. So obviously, since they couldn't recruit her, her husband had a thriving dental practice in New Haven and was not willing to come to Pittsburgh. They figured I'd be a good substitute. And I had an undergraduate degree, an undergraduate job in the library at my undergraduate institution, so I was pretty good at looking things up. And as a theater major and an English minor, I was pretty good at writing, so I could fix their Hungarian papers. And would continue to do that, find the references, fix the English. But at the end of the day, I kept asking these questions, particularly as they were working on a book on the introductory interview in psychiatry. And finally, I think just to shut me up, they gave me a bunch of data that they had brought from New Haven, and nobody was working with the data, so they actually also gave me a statistician to work on the data, and I thought, well, this is pretty interesting. Let's see what we can do with this. It was a bunch of questionnaires that had been given to couples who were seeking sex therapy and marital therapy in New Haven. And I thought, well, let's see if they're the same or different. I wrote the stuff up. It got accepted for presentation at the American Psychiatric Association. I thought, this is a pretty easy game. I think I'll play this game for a while. But it did occur to me that I probably couldn't do that without some kind of degree other than a bachelor's in theater and a master's in English. So I applied to our clinical psychology program and actually was put on the waiting list, but eventually the waiting list cleared and I got a position. The paper I presented at the APA went on to appear in the American Psychiatric Association's journal. We subsequently looked at actual sexual problems in the happily married couples that Carol Anderson and I recruited in the Pittsburgh area. And we found that even happily married and sexually satisfied couples often reported problems with sexual interest, arousal, and orgasm. But that area of research really didn't lend itself to further pursuit. But what happened was that the National Institute of Mental Health put out a request for proposals to study victims of sexual trauma. I had through my television show, been involved in the founding of the Rape Crisis Center in Pittsburgh and was very much integrated with the rape crisis movement in Pittsburgh. So Dr. Detry didn't have anybody else to write a grant in that area. I'm now a first-year graduate student. He said, Ellen, you want to write a grant? I said, why not? More seriously, working together with Sam Turner, who was a very important influence in my development as a behavior therapist. We did, in fact, write a grant application. It was not approved on the first round, but when we brought Marika Kovacs in on the grant to train the therapists to do cognitive therapy, Sam trained the therapists to do systematic desensitization. We were able to get this grant funding. So as a second-year graduate student, I had my first R01. Not your usual path up the stairway. But in addition to testing the treatments, what we learned was something very unexpected. The literature to that point on rape victimization had really focused tremendously on anxiety. And what we observed in the women that we saw was that depression was equally prevalent. In fact, at least as prominent as anxiety in the immediate aftermath of rape. What we've also learned over the course of a series of renewals of this application was that early behavioral, systematic desensitization, or cognitive, classic Beckian cognitive behavior therapy reduced both depression and anxiety in the women that we were seeing. But also, in the absence of early intervention, depression and anxiety tended to persist. But if we were able to institute later intervention, we were also successful in reducing symptoms once treatment was initiated. Now, while we were carrying out this study on the 8th floor of the Western Psychiatric Building, the other half of our floor was dedicated to the conduct of a large NIMH trial that was focused on the question of the treatment of recurrent mood disorders. And at that time, I think it's very important to recognize that while bipolar disorder was definitely thought of as a lifelong condition, unipolar depression was really thought of as something that happened in unique and disconnected episodes. There really wasn't a focus on the recurrent lifetime version of this illness. But Robert Prine, who was at the National Institute of Mental Health, did really understand how lifelong unipolar depression was and designed a study in which both unipolar and bipolar disorder patients were included in acute therapy, then followed with continuation therapy. The individuals in the trial had to be able to be stabilized on the combination of lithium and imipramine. At this time, we didn't really know whether lithium could be an effective treatment for patients with unipolar disorder. And then those who were able to be stabilized on lithium and imipramine were assigned to a maintenance treatment program. For the patients with unipolar disorder, they were randomly assigned to lithium plus placebo, imipramine plus placebo, double placebo, or the combination of lithium and imipramine. There was the assumption that patients with bipolar disorder were not appropriately randomized to double placebo. So the bipolar arm of the study followed patients who were treated with lithium plus placebo, imipramine plus placebo, and lithium plus imipramine. The results of the study were remarkably clear. Patients with bipolar disorder who received lithium had significantly superior outcomes to those who received only imipramine. But I will have you note that the outcomes were not so great. That is, more than 50% were ill again after 2 years, even when lithium was provided. We focused on whether or not we could improve outcomes for patients with unipolar disorder. In the unipolar arm of the trial, patients on double placebo fared quite poorly, with almost 3/4 of patients ill again after 2 years. But what we saw was that the combination of lithium and imipramine initially looked significantly better than either lithium alone or imipramine, either lithium alone or imipramine alone. But by the time we got out to 2 years, it really appeared that imipramine was the relevant treatment. But we thought we could do a lot better than that. If you'll notice, again, a substantial proportion of patients were ill after 2 years. So we focused on 2 aspects of the trial, only one of which we put to an experimental test. We focused on the fact that individuals, even those individuals who remained well for 2 years, had significant deficits in social functioning. So we thought that perhaps if we added a treatment that focused on patients' social functioning, in particular Clairman and Weissman's interpersonal psychotherapy, that we could improve outcomes for those patients. We also made a critical decision, and that was to go against the conventional wisdom. In the Prine et al. Trial, once patients were stabilized and entered into the maintenance phase, whatever pharmacotherapy they were on was reduced by 50%, because there was the assumption at that time that maintenance treatment didn't need to be at the same level as acute pharmacotherapy. So the study design that we developed was a 3-phase study, excuse me, in which patients with recurrent unipolar disorder, and in contrast to what Dr. Linehan was arguing in the previous lecture, we certainly did include patients who had suicidal thinking. These were all patients who had recurrent depression, at least 2 previous episodes, and the current episode no more than 2.5 years after the previous episode. So these were patients who had multiple episodes and frequent episodes. In fact, the median number of previous episodes in the trial was 4. We stabilized patients on the combination of pharmacotherapy and weekly sessions of IPT for 12 weeks, which were reduced to 8 weeks, and then finally to monthly. At whatever point the patient had 3 weeks of stable scores, Hamilton less than or equal to 7, and a Raskin depression rating less than or equal to 5, the individual then was moved into a continuation phase, during which their treatment remained stable. And then finally, we randomly allocated patients to maintenance IPT alone, which was monthly sessions of IPT, and imipramine maintained at the same dose that had been used to treat the acute episode, whatever that was. Medication clinic visits plus placebo, we referred to this at Pittsburgh lovingly as recipe or baseball therapy. It was 20 minutes with the same clinician who had treated the patient during the acute phase, but the clinician was constrained from doing anything that represented an IPT approach. So we joked that with the guys, we mostly talked about baseball, and with the women, we mostly talked about recipes, in order not to do psychotherapy. Medication clinic and imipramine, or our reviewers insisted that we also include an IPTM and placebo condition. We treated patients for 3 years or until they experienced a recurrence of illness. What we found was that maintaining the dose at the same level as had been used to treat the acute episode was associated with a remarkable improvement in long-term outcomes. The cumulative probability of remaining well for patients who were maintained on full-dose pharmacotherapy was about 0.8. enormously better than in the Prine et al. Trial. For patients who were assigned to the medication and placebo condition, outcomes were very poor indeed, with only about 20% surviving, cumulative probability of remaining well of about 20%. But interestingly, those patients who had received monthly sessions. Now, and you have to think about this, that we're coming out of the era when psychotherapy was thought of as 5 days a week for 5 years. So these were monthly sessions of IPT over the course of 3 years. These folks clearly had an intermediate outcome. Cumulative probability of remaining well over the whole period was only about 0.3, but if we look at median survival time was well over a year. What we also saw in this trial was that by listening to audio tapes, we could identify those individuals, or really I should say those dyads, that were able to focus consistently over that 3-year period on the strategies and tactics of IPT, on the themes of IPT. So for those individuals who were in IPT alone or IPT plus placebo, who together with their therapists were really able to focus on these IPT themes, we had excellent probability of survival, almost as good as on medication. The patients who were not able to really focus on IPT themes, or whose therapists weren't able to focus on IPT themes with them, they did just as poorly as patients who were not assigned to psychotherapy at all. So what we learned was that maintaining pharmacotherapy at the acute treatment dose was associated with excellent protection. Monthly psychotherapy did not add significantly to that outcome, but in essence, we had topped out. Excuse me, there was no room to add to that efficacy. But if patients and therapists focus on IPT themes in those who were being treated with IPT alone, we did see significant protection against new episodes of illness. And at this point, I began to see that there was a stairway. And the person who really showed that to me was Julius Axelrod, basic neuroscientist. Odd that he would be the one. At the time, we had a clinical research center for depression at the University of Pittsburgh. Every time the clinical research center met with its advisory board, which included Dr. Julius Axelrod, we had a lovely dinner for our advisors. And I would always be seated at the table with Dr. Axelrod, who would talk about how research proceeded in his laboratory, which was unthinkable to someone who was doing studies that lasted 5 years. But he would talk about going into his lab in the morning, reading the results of the experiment that had been done the day before, think about the results of that experiment, and around 3 or 4 o'clock, he would call all his postdocs and junior associates into his lab, and they would discuss the experiment they would do that night, and then he would get the results the next morning. But what I heard was that there was an iterative process of hypothesis testing, hypothesis generating, which led to more hypothesis testing, which led to more hypothesis generating. And it began to dawn on me that what we were doing in our program was exactly the same thing, except our time frame was 5 years instead of 24 hours. What the results of that initial unipolar depression study led me to think about was, if IPT alone provides good prophylaxis to some patients, who are the patients who would really want to be treated without pharmacotherapy? Patients with highly recurrent depression, but who might want pharmacotherapy to not be a part of their treatment. And we focused on women in the childbearing years. So we knew that it would be too difficult to recruit exclusively pregnant women. So we simply focused on recruiting women who met those same criteria, at least 2 previous episodes, most recent episode no more than 2.5 years ago. And we brought them in and treated them with IPT alone for their current depression. If they remitted, they then had a continuation treatment of 17 weeks, again with IPT alone, and then they were randomly assigned to weekly, biweekly, or monthly IPT. The idea being that if monthly IPT was only partially efficacious in preventing new episodes of depression, could we do better with biweekly or weekly sessions? We knew that not all of these women would remit with IPT alone, and if they didn't, we added pharmacotherapy. At this point, the SSRIs had come on the scene. So we added SSRI. If they stabilized with SSRI and IPT, we then discontinued the SSRI and randomly assigned them again to weekly, biweekly, or monthly treatment. What we found was that IPT alone clearly has a role in the treatment of a large set of women with seriously recurrent depression, but there was absolutely no difference among the weekly, biweekly, and monthly versions of IPT in terms of prophylaxis. But look at that level of prophylaxis. Cumulative probability of remaining well over 2 years, around 0.75. Not bad. Again, the average woman in this trial had had 4 previous episodes of depression. So you didn't need any statistic to see that these were not different. But we also then looked at what happened to the women who required SSRI to achieve remission. And what we saw was that among those women who required an SSRI to achieve remission, regardless of the frequency of IPT, they had a much greater probability of recurrence over the 2-year maintenance phase. So we learned that quite a lot of women with highly recurrent depression could achieve a sustained remission with IPT alone. We're not just talking about response, we're talking about a clear-cut remission. Among those women, even monthly sessions were effective in preventing new episodes of depression, but among those women who required medication to achieve remission, the risk of recurrence with IPT alone, we felt, was unacceptably high. But I still was worrying about those folks with bipolar disorder, particularly moved by having attended a conference of what was then called the Depressive and Manic-Depressive Association, now the Depression and Bipolar Support Alliance. I, like many people in our field, really believed that bipolar disorder was largely a problem solved. But I should have known from the Prine et al. Outcomes that half of patients were ill again within 2 years, even when treated with adequate levels of lithium carbonate. So I thought we really need to do something about this disorder. We need to take a different approach. And there was at that time a recognition, largely coming out of a meeting that Bob Prine organized at the NIMH, that outcomes for bipolar disorder were inadequate. And there was a group of us, all kind of growing up at the same time, that said, well, maybe psychotherapy. This was our sort of most biological, most genetic disorder. Why would you think psychotherapy might be helpful? But David Miklowitz and the late Michael Goldstein, our group at Pittsburgh, and several groups interested in cognitive therapy believed that there might be something to add. I'll just remind you of how poor the outcomes were, even for the folks treated with pharmacotherapy. Now, as I was coming back from this depression and manic depression conference, I was reminded of a theory that we had developed out of a MacArthur network on the treatment of depression that was referred to in the introduction. We referred to it as the social Zeltgeber theory of mood episodes. Zeltgeber meaning, it's a term that comes from circadian rhythm research. It means a time giver. If you think about a metronome, something that really sets the rhythm. And what we argued was that life events had their power to affect mood, not through their psychological meaning, of course, as George Brown had shown, but in addition, not only through their psychological meaning, as George Brown had shown, but also by their capacity to change the social prompts in our lives, well, the things we refer to as social Zeltgebers. So if you think about an event like really any life transition, from being a single person to being a married person, from being a student to being a working person, from being a working person to being a retired person. All of these life events may have great psychological meaning, but they also change the timekeepers in our lives. And what we said was that those changes in social prompts lead to a change in the stability of our social rhythms or social routines, and that in turn leads to a change in the stability of our endogenous biological rhythms, and that in turn leads to a series of somatic symptoms. Now, I don't know if anyone here in the room came to New York from, let's say, the West Coast. But if you did, I can tell you that you're a little nauseated right now. You probably have a little bit of a headache. You're having difficulty concentrating. Your mood isn't all that great. Your level of sexual interest is in the basement. And does this sound like any disorder we know about? So what we said was that this change in somatic symptoms that occurs as a result of this cascade is a perfectly normal one, and that we all experience when we are severely challenged in terms of our social prompts. But what we said was that individuals who are vulnerable to mood disorders get stuck in what we might think of as a kind of pathological entrainment of biological rhythms that we refer to as manic or depressive episodes. And we actually did some studies that demonstrated that this was true. We took George Brown's life events and difficulties schedule and added to it a rating of the extent to which an event was likely to have disrupted one's social routine. So we added a kind of social rhythm disruption measure to the George Brown method. And what we saw was that when we compared patients with bipolar disorder in a period that immediately preceded the onset of an episode of mania or depression with a control period in the same year, but not during a period that preceded an episode of either mania or depression. What we saw was, to no surprise, that severe life events, as defined by Brown, were much more common in the pre-onset period than in the control period at some other point during that year. But what was really striking was the extent to which social disrupting events were present in that, social rhythm disrupting events were present in that pre-onset period, particularly for individuals who experienced an episode of mania. So, at the same time that we were doing this work, we designed a treatment based on the hypothesis that if we could develop a treatment that focused on the interpersonal aspects of patients' lives and on their capacity to maintain really regular social rhythms, in the face of disruption, that we could increase the stability of their social rhythms, that we could increase the stability of their biological rhythms, and increase their ability to manage interpersonal stressors, and that would lead to decreases in mood symptoms and an increased ability to manage disruptive life events. So we designed a study in which we entered patients who were in an acute episode of mania or depression, all patients with a bipolar I disorder, and randomly assigned them to one of 4 treatment strategies: acute IPSRT and pharmacotherapy, largely lithium, followed by IPSRT in a 2-year maintenance phase, or what we called intensive clinical management, sort of good lithium clinic management, followed by good lithium clinic management for 2 years, or IPSRT followed by intensive clinical management in the maintenance phase, or intensive clinical management followed by IPSRT in the maintenance phase. What we were asking were really a series of questions. Could a bipolar disorder-specific psychotherapy accelerate recovery from acute episodes of depression and mania? Would it decrease the risk of recurrence of depression or mania? When would we want to start such a psychotherapy? Do you engage the patient in psychotherapy when he or she's acutely ill, or do you wait until the depression or the mania has subsided? And what factors might moderate outcomes with such a treatment? And what factors might mediate outcomes with such a treatment? So we developed what we called IPSRT, a very behavioral effort to focus on the link between mood and regularity of social routines using a self-monitoring instrument we call the social rhythm metric, using every trick in the behavior therapist's book to move patients toward very regular routines. And we combined that with Klarman and Weissman's interpersonal psychotherapy that focuses on the link between mood and life events, with the same focus on grief, role transition, role disputes, and interpersonal deficits. Now, when we talk about IPSRT, we have to talk about it as though these are 2 separate modules, but in practice, one constantly interweaves the focus on the interpersonal with the focus on social rhythms. Indeed, if you think about the main problem areas of IPT, an unresolved grief, a role transition, a role dispute, each of these has tremendous capacity to disrupt one's social routines. So working in these problem areas, it's very easy to focus on the importance of maintaining regular social routines. Our intensive clinical management treatment was not nothing. The comparison was not nothing. It included a lot of psychoeducation, a careful review of side effects, medical and behavioral management of side effects, nonspecific support, recipe and baseball therapy, educating patients about their early warning signs, and the use of rescue medication and a 24-hour on-call service. And in fact, we were really comparing intensive clinical management plus IPSRT with intensive clinical management alone, because all of the patients in IPSRT also got all of that. So we were able to complete a study in which patients entered acutely ill, stabilized, and continued in 2 years of prophylactic treatment. The results, one of the things I learned is that when you go into a randomized controlled trial, you almost never find what you expect to find, but that if it's well designed, you find something fairly interesting. So, to our complete surprise, what we found was that after we adjusted for some variables that did not work out well in the randomization, marital status, anxiety disorder, and medical burden, if you got IPSRT as your acute treatment, you remained well significantly longer in the maintenance phase, and it didn't matter whether you got IPSRT in the maintenance phase or not. That was really, so 12 to 18 weeks of IPSRT, and it protects you for 2 years. That was really shocking to us. But when we thought about it, it made sense, because IPSRT is really an educative treatment. And either patients got it during the acute phase or they didn't get it. And if they got it during the acute phase, then they were able to remain well they had a greater probability of remaining well for the next 2 years. What was really satisfying to us was that, as we heard in the introduction, the more patients were able to increase the regularity of their social routines in the acute phase, as measured by the social rhythm metric, the longer they remained well in the maintenance phase. So what we showed was that increased regularity of social routines actually mediated the response to IPSRT. In other words, there was something to our theory. We moved on in another direction at this point, back to unipolar depression. Well, really not. Back to a more dimensional way of thinking about the categorical disorders that constitute the psychiatric nomenclature. This was work done together with Giovanni Cassano, one of the, I think, most innovative thinkers in psychiatry in the 20th century. And what Cassano had said was that patients who meet the criteria for a DSM disorder often manifest a spectrum of related symptoms, behavioral tendencies, temperamental traits that aren't in the diagnostic criteria, or at least weren't in the diagnostic criteria in DSM-4. I'd like to think that we got a lot more of this into the criteria in DSM-5. And what Cassano argued was that recognizing these clinically significant features can improve the doctor-patient relationship, identify clinically meaningful subtypes, and guide treatment decisions. That's the key there, guide treatment decisions. And that spectrum features may be present both in those who don't actually meet the criteria for any diagnosis, but they often appear as comorbidities. And that was what made me think that maybe we could use this spectrum concept to help us make one of what I saw as the most important decisions in the treatment of depression. And that is, do you start with pharmacotherapy or do you start with a depression-specific psychotherapy? We really had no guidance in that arena. So working together with Cassano, and you may recognize a few American psychologists here, Jean Endicott, Jack Mazur. This was the spectrum study group in that beautiful setting in Pisa where they have palm trees. And this really represented a kind of humbling return to concerns about the treatment of unipolar depression. We developed a 2-site study conducted at Pittsburgh and Pisa in which we entered almost 300 patients with unipolar depression, not necessarily recurrent, but a very substantial proportion of them did have recurrent depression. We had a 12-week acute phase, or until patients stabilized. So they were assigned randomly to either receive SSRI or IPT. And if they responded, we continued that treatment. If they did not respond to the initial monotherapy, we added the other treatment. If they stabilized, we then kept them in continuation treatment. If they didn't stabilize, we switched to a second antidepressant treatment, and we continued treatment for an additional 24 weeks. What we did was use these spectrum measures that we had developed with the Cassano group, that focused on mood spectrum, panic-agoraphobic spectrum, obsessive-compulsive spectrum, and social phobia spectrum, and looked at them as predictors and moderators of outcome. We used Cox regression models to analyze the effects of each of these predictor moderators, along with site treatment and their interaction. What we found was that the spectrum measures provided very good treatment, very good prediction of who would be difficult to treat with either medication or psychotherapy. Lots and lots of significant predictors with good effect sizes. So, but not much in the way, and actually site and marital status predicted who would be likely to get well more quickly. But we really found only a very small number of moderators of treatment outcome. What we did find was that patients who were higher on the moods psychomotor activation, so these were the more energized patients, did better if they received IPT, and those who had a higher need for medical reassurance did better if they received SSRI as their first treatment. And if you think about it, in IPT, we focus on social relationships and social roles. In the contrast condition, we were focusing on the patient's medication and side effects, all somatic concerns. So this made a lot of sense to us. But it definitely wasn't enough to go to the bank in terms of making a clear-cut treatment decision. But once again, we found something that was kind of unexpected. And that was how remarkably well patients did with this strategy of beginning with monotherapy and adding the other treatment if monotherapy wasn't successful. If you look at this, by 3 months, we have over 50% of patients in a stable remission. And between 3 and 9 months, we have over 80% of patients in a stable remission of depression. And the same was true regardless of whether we started with IPT alone or SSRI alone. And I think the study really argued for that strategy. We found some good predictors of who's likely to do well, but only one moods and one pass factor that distinguished IPT responders, or I should say remitters, from medication remitters. But that this strategy was really effective. Okay. I just want to touch briefly on 2 things that we're doing now that I think are really important. One is trying to understand how to get these treatments out to a broader audience. This was a study that we did together with Brad Stein, a services researcher. What we did was randomly assign clinics to either in-person training, standard 2 days, come to a site, sit still, listen, or to an internet-supported collaborative learning enterprise. And in the e-learning enterprise, we created staff implementation teams. We created learning collaboratives at the clinic so that, again, therapists weren't out there on their own trying to learn how to do this, but working together. Because we were working in community clinics, we couldn't do tape recording of sessions. That just wouldn't fly. But what we did was ask the patients to tell us what their therapists had done during the sessions. And what we found was absolutely no difference, excuse me, between the therapists who had been trained in the standard face-to-face 2-day training and those who did their own training over the internet. In terms of the probability that the therapist was using, in this case, IPSRT techniques. So we found that it's possible to engage community clinicians in web-based training, and that the patients of such clinicians actually report just as much use of the EBP techniques. The last thing I'm going to talk about is asking the question, can we move these treatments directly to patients by using the ubiquity of smartphones? So we are in the process of developing a smartphone app for self-monitoring and self-management in patients with mood disorders. We're capitalizing on what the phone can sense as well as what the patient can record. We're providing feedback to patients in terms of, are they getting more rhythmic or aren't they? And we're enriching the clinician-patient interaction by providing the same kind of feedback to the clinicians. So my disclosures include royalties from Guilford Press for the IPSRT manual and the American Psychological Association for a lovely little book on interpersonal psychotherapy. So I just want to thank our wonderful research team at the University of Pittsburgh, David Kupfer, who taught me most of what I know about how to do a randomized controlled trial, and my mom. My mother was a truly innovative social worker in the Pittsburgh area and taught me most of what I know about how to help patients while we dried the dishes. And finally, our study participants for their time, their energy, and their trust so that we could continue to try to relieve the burden of mood disorders. Thank you.